Greetings everybody and welcome to a special Black Friday edition of COPD Navigator Live. My name is Mike Hess and I'm a respiratory therapist and COPD educator. And this is our weekly look at inside the world of COPD. We are going to be covering, our big topic for the day is going to be oxygen, but we do have a few things to talk about beforehand. First of all, of course, yesterday in excuse me, in the U.S. at least, it was Thanksgiving. So I hope everybody had a very joyous and celebratory Thanksgiving feast with family and friends and everybody else you care about. I know I personally have a lot to be thankful for this year. First of all, I'm very grateful for the COPD Foundation for allowing me to have this platform to help share some information with you. I do run a group here on Facebook for COPD information and support called COPD Navigator. That's where the Navigator Live comes into things. We started doing these weekly talks back in February, and for this month, COPD Awareness Month, the foundation has been gracious enough to allow me access to help get the message out to a wider level. So as we start wrapping things up here in COPD Awareness Month, I would like to invite everybody to, of course, join the COPD Foundation COPD 360 social website and our group here on Facebook, COPD Navigator. You can go to facebook.com/groups/COPD Navigator or use the little search bar and search for COPD Navigator and find us there. Also, you can find previous editions of COPD Navigator Live by going onto YouTube and searching for COPD Navigator. We do these, like I said, every week. And we cover a half hour of a particular topic of the day and then a half hour of question and answer. So if you have any questions on your mind, whether it's about oxygen or whether it's anything else here in COPD, whatever's on the mind of the COPD world, please type in those questions now and we'll get to them as we get through the program here. For those of you who may be longtime watchers or have at least seen the program before, you may notice that things do look a little bit different around here because this is, of course, the day after Thanksgiving. My office is actually closed today to let everybody celebrate, and which puts me in the home office for today. So I decided to go a little bit more casual. And that's why hopefully things will go pretty smoothly today, but this is a little bit new equipment for the setup here. So if anything happens to go awry, please let me know by typing a comment, and we'll try to get it addressed as soon as possible. You may also notice I'm going a little bit casual today in honor of having the day off. I decided to wear, instead of my usual outfit, my new COPD awareness shirt, special for this month of November. To raise awareness wherever I go. I was able to wear this to my Master's in Public Health class a few weeks ago, and I've been wearing it around town as much as I can, as this is COPD Awareness Month, and we're trying to get the word out for a lot of this stuff. Of course, yesterday being Thanksgiving means today is Black Friday. Hope everybody got whatever you needed out of the day. I'm not a big shopper on Black Friday anymore. What I do shop for, I usually do online. Back in the younger days, I was known to get out and stand in line from time to time, but there's just other stuff going on now. Of course, Black Friday has begotten a couple of other celebrations in the next few days. For better or for worse, involving monetary transactions. We've got Cyber Monday coming up on Monday, obviously, but perhaps more importantly, we have Giving Tuesday coming up on Tuesday. Giving Tuesday is a way for everybody to contribute to great efforts like the things that the COPD Foundation does and a lot of other local and national charities. And why this is relevant is because you too can get one of these beautiful orange COPD awareness shirts by going to this link that I'm about to copy and paste here for you. There we go. CustomInk.com has teamed up with the COPD Foundation to create these awareness t-shirts, and the foundation is using it as a fundraiser. We do need to get a few more commitments to buy more shirts before we do another batch toward the end of the month. So I encourage everybody to go to CustomInk.com and follow the link there. These shirts are $15, and again, everything goes to the COPD Foundation. Makes a great gift for Charitable Tuesday, Giving Tuesday. and of course supports a lot of awareness and research efforts. Now, with that out of the way, we can cut into our next feature here on COPD Navigator Live, trying to cover some of the news of the last week in the COPD world. Perhaps the biggest news this week, this is actually a topic that came up in our group, COPD Navigator, here on Facebook. Earlier this week, talking about a particular kind of white blood cell called an eosinophil. It's a type of white blood cell, type of immune response. It can kind of measure some of the inflammation and some of that stuff going on inside your lungs, which of course is a hallmark of COPD. And so researchers found, or published at least in the last week or so, in a journal called The Lancet, which is a very well-respected British medical journal. They found that if you measure the number of eosinophils in a person's mucus or sputum, all this stuff we talked about last week, that can be a little bit better predictor of your inflammation and your severity of COPD than doing a simple blood eosinophil test. That's kind of been where the standard has been for a very long time, looking at the blood eosinophils, but we're seeing that maybe measuring them in the mucus might be a little bit more effective. In terms of severity, they found that people who had higher eosinophil counts had a lower FEV1, that forced expiratory volume in that first second, that big spirometry measure that we often look at. We also found that those people tended to have a higher degree of emphysema or air trapping, which was measured by a CT scan. And those people with the higher eosinophil sputum counts were more likely to experience an exacerbation that required steroid therapy. So by many different measures, people with those high eosinophil counts in their sputum tended to have more severe COPD. So we're looking at maybe making that a benchmark to figure out exactly how to guide therapy during the exacerbation. And of course, this is another starting point to try to get a more objective view of how things can go or how things should be measured in the outpatient, the management of stable COPD phase. The other biggest thing on the COPD news front is this Sunday, famed newscaster Ted Koppel and his wife Grace Ann Dorney-Koppel are going to be appearing on CBS Sunday morning, talking about COPD awareness activities. This is, again, COPD Awareness Month, and Grace Ann was diagnosed with COPD about 15, 16 years ago, and has done a lot in the world of advocacy since then, including doing a stint as the leader of the COPD Foundation. She also does a lot to improve access to pulmonary rehab and does a lot of funding to get pulmonary rehab centers off the ground and increase access to those services. This past week, CBS had a little bit of a preview, and we'll copy a link to that here. Had a little preview of what they're going to be doing on this Sunday. And then, of course, you can view that at the link that was just commented there. And then another preview discussion coming up here courtesy of CBS right there. And then tune in Sunday morning here on the East Coast. It is, I believe it begins at 9 o'clock Eastern Time. So be sure to tune in. You can also stream it live not live, but you can stream it after the fact if you're not able to catch it bright and early Sunday morning. Will be available through CBS's website for a while, and I imagine we're going to be seeing a lot more come out through the foundation as well once that interview gets done. So that wraps things up for our COPD news of the week. We're going to look at our big topic today, which is oxygen. Oxygen is something that many people use during the course of their time with COPD, especially as you get into some of the more severe phases of the disease. So let's take a look at why exactly you would need to use COPD, or why you would need to use oxygen. It helps to kind of get at a very basic level. We'll take a look at how oxygen works inside of your body. Basically, you have red blood cells that everybody's kind of familiar with them. That's what gives your blood, obviously, its red color. Those are kind of like the boxcars of your respiratory system. When you breathe oxygen in through your lungs, it diffuses into your alveoli and across that barrier and hooks onto those red blood cells, kind of loads up the boxcars with cargo. And then everything ships off down the tracks of your circulatory system, bringing the oxygen fuel from your lungs all the way out to your various other organs and your skin and all your other tissues and everything else, where it offloads the fuel, picks up some carbon dioxide, which is a waste product, ships everything all the way back through the veins, and then everything, carbon dioxide, goes out through the lungs. And that's going to be important in just a minute here. Because a lot of times we see that when we have trouble with oxygen, when we have trouble breathing, we can't necessarily get in enough oxygen, we can't necessarily blow enough carbon dioxide out. And we measure oxygen through the use of a device called pulse oximetry. A lot of times, many of you may be familiar with a device that goes on the tip of your finger usually. Sometimes it can clip onto your ear, but it measures your oxygen level. Actually, nowadays, you can even get the things on your phone here. I don't know how well I can see that. It doesn't like the fact that I'm talking so much, I guess, but we can hopefully get a measurement here. And what this does is, this will, give it a second here. Hopefully I have at least some oxygen floating around in there. There we go. All right, and this measurement is telling me that I have 100% oxygen going through my cells. Now, what does that mean? Oxygen, or the percentage there, the percentage saturation, is a measure of how full those boxcars are. See, red blood cells are a slightly different color when they have oxygen on them as when they don't. And what happens is, if let's see if I can get another measurement here, so I can kind of show you what's going on with this thing. What these oximeters do is they shine, you can't really see it real well, but they shine a red light on your finger, and then the particular wavelengths of oxygen saturated light are reflected back to the sensor, and it does a lot of math and all that kind of stuff and figures out exactly how many red blood cells have oxygen attached to them. In my case, 100% of the oxygen, or the red blood cells, have oxygen attached to them. In many other cases, that number will go down a little bit, especially when you're having trouble bringing oxygen in and blowing carbon dioxide back out. We see that those numbers can dip down into the mid-90s, into the low 90s, and even below 90 into 88, 85%, that sort of area. That app, this particular app, is called Samsung Health. I have a Samsung phone. It comes pre-installed on that. There are a variety of other apps on there, depending on whether you have an iPhone or an iDevice, or whether you have an Android. I'm sure if happen to be out there still with a Windows phone or even a BlackBerry, there are probably some apps poking around out there somewhere. There's something available for that. However, we're going to get into a little bit of caution with these kind of apps in just a minute here. I just want to kind of wrap things up on this front. So what these devices do is they shine the red light. They figure out how much is getting reflected, and with that they can extrapolate or figure out how much blood or how many red blood cells are actually carrying oxygen. And the problem with that is oxygen is only one part of the picture. I get a lot of times asked the question, why am I short of breath if my oxygen level is good? I just measured my oxygen. I'm not using supplemental oxygen. I just measured things. It's 98%, but I'm out of breath all the time. Well, unfortunately, we've got to remember a couple of things. First of all, again, these are just measuring how full those boxcars are. If you have fewer boxcars, even if they're full, they're not going to be able to transport enough oxygen to get to all of your systems. If you have a heart issue where the boxcars maybe can't move fast enough, you're to keep up with demand. Your body is going to want more, and your brain interprets that as being short of breath, because when you want more oxygen, your main mechanism of doing that is to breathe faster. And when you can't breathe fast enough, that is what your body or what your brain interprets as shortness of breath. And again, we've got David mentioning, that's my problem. It reads 97, 98, but yet I get tired. Absolutely. That happens very often. And when you think about it, it does happen even when you have perfectly healthy lungs too. If I were, we saw a minute ago, I was measuring 100%. If I went outside and ran around my block 2 or 3 times, I would be huffing and puffing a lot too, because my respiratory system can't keep up with demand. That's what happens in COPD, except your threshold is a lot lower, obviously. Because your lungs have damage, they aren't as efficient and they can't do that, and so you get shorter breath even doing basic activities around the house a lot of times. Or I'll ask this, what is a normal O2%? And that brings us into our next topic here. There is, from a clinical standpoint, there is not a whole lot of difference between, say, 90% and 100%. So if you're measuring 97%, that doesn't mean that you're sick or that you're not, or that you're having an exacerbation or anything like that. Most people usually range somewhere between 96 and 100. There's kind of we have this thing, I don't want to get too into the chemistry of it, called the oxyhemoglobin dissociation curve, but from a basic, if you're looking to take a nap later on, or if you haven't had enough tryptophan and you're trying to get to sleep, do some Google research on the oxyhemoglobin dissociation curve, and it'll take care of that right away. Anyway, from a practical standpoint, we see that between 90 and 100%, or 100% 90, I guess, the curve is pretty flat. Doesn't really make much of a difference. Once you start hitting about 92 to 98%, we start getting into that curve there, and once you hit below 88%, it goes down really fast. And so small changes in your percentage can make a big difference in how you feel and how much oxygen you're carrying. And so that's why we usually look at giving people supplemental oxygen once they hit that 88% threshold. That's the usual Medicare payment. That's or the Medicare payment criteria. That's where a lot of other insurance companies go with that 88% or below. Because once you're above that, then you're actually doing pretty okay. You might be skirting on the edge. You might not be doing fantastic, but you're doing okay that you don't need to carry the oxygen around. So once you get below that 88%, David, that's a great point. Don't actually huff and puff, but do get chest tightness and feel like you can't take a deep breath in. That is another symptom. If we look at what we call the COPD assessment test, which is a very simple, straightforward test that we use here in our clinic to kind of get a glimpse of what symptoms are for a person, that is one of the key symptoms where you have that chest tightness. Everybody is going to pick up that sensation of shortness of breath in different ways. Sometimes you're gonna want to breathe faster. Sometimes it's going to be more of a chest tightness where you just can't feel like you can take a deep breath, because that's another factor in the whole why am I short of breath thing. Again, we talked about the oximeter and why you can be short of breath when your oxygen is good. Not only is the oximeter only measuring how full the boxcars are, it doesn't measure anything at all with carbon dioxide. And you have two main receptors of your body, or your two main drivers of your body telling you to breathe more. Either your oxygen is low or your carbon dioxide is high. It wants to blow things off. And so this oximeter doesn't really measure anything with carbon dioxide. And so you can start having some of that carbon dioxide build up inside of your lungs, and you want to breathe faster, but again, you can't necessarily move that air out. We talked a lot last week about pursed-lip breathing, because sometimes those very small airways right before the alveoli where the gas gets exchanged can tighten down and trap a lot of that air. We talk a lot about air trapping. We talked on CT, we found that those people with the high sputum eosinophils had air trapping. That gas gets trapped in there, and yes, it still does have some oxygen, so it can still fill up those boxcars, but you're also building up the CO2 because it's not getting out. And so your body wants you to start breathing faster because you're building up that carbon dioxide. And so shortness of breath can be driven not only by a low oxygen, but also by a high carbon dioxide. And so it's important to not necessarily rely just on the oxygen or the oximeter to figure out why you're having or to try to figure out why you're having a bad breathing day or something like that. It is one of the tools that we use, but certainly not the only tool that we use. Excuse me for just 1 second. So it's important to stay hydrated. We got to keep that mucus moving, right? We got to make sure everything is hunky-dory down there and keep things thin and able to cough it out. So we definitely want to stay hydrated. So we will address some of these other questions here. I do want to keep going on the oxygen real quick here, but I am seeing these, and I definitely do want to move forward. I would love to do closed captioning, but unfortunately I don't have that technology right now. We're looking at trying to get that established for the YouTube versions, but thank you for that tip, and I would definitely love to support that as much as possible. However, supplemental oxygen, once we hit that 88% range, we see that that's when you start getting into kind of the danger zone of where things go bad for your organs. When you're below 88%, you start having issues with your brain, your heart's working a lot harder and can cause problems with your heart. A lot of your organs can start to fail once you get below that 88%. So what we do is we give people extra oxygen. You've all seen, and many of you hopefully use, if you've been prescribed it, hopefully you're using it, the old cannula in the nose, where you have that little rubber tube that goes in your nose, usually over your ears, and then down to an oxygen system. What that does is that kind of, because your lungs don't work quite as efficiently, we give you a little bit more so that we can kind of flood the system, so to speak, and get a lot more oxygen in there, so that your body can absorb it a little bit better, and it can move a little bit better inside of your bloodstream. A couple of different methods to do that. Most people, especially if you need oxygen at rest, we have a home concentrator system that's probably the size of a small cooler that sits in a corner somewhere and pumps out extra oxygen. It has a molecular system inside where it can actually sort of condense some of the oxygen from the air and then pumps it out to your nose, where you breathe it in and get that supplementation. Works great as long as you are able and willing to stay within usually about a 50-foot tether of the device and do all of your activities without tripping over the hose. Of course, we do encourage everybody with COPD to get out and moving as much as possible, so we want to have people, we want to enable that with the use of portable systems. A couple of main types of portable systems. Probably the most common is the old school oxygen tank. Usually a silver and green canister. Sometimes they're about yay big that you can carry them around with you on a shoulder pack. Sometimes they're got to fit everything into the thing here. Anyway, they're pretty big, and you drag them behind you on a cart. Those come from a gas company. In most cases, sometimes you can actually fill them through your concentrator with if you have a particular types of adapters on there. You can fill those with your home concentrator, but the point of it is you have a finite supply, a limited supply of oxygen gas to carry around with you. These work fairly well in that they are usually relatively cheap. They are fairly portable, although they can be on the heavy side certainly, and or if you're dragging it around, that's kind of a bummer. And of course, they have a fairly limited time frame. So another piece of technology we have is they were able to take that big cooler thing sitting on the floor concentrator and turn it into a portable device that you can sling over your shoulder, carry around with you, and have that same kind of technology blowing. Instead of having a tank, you have this device that is concentrating oxygen out of the ambient air, the air floating around you, and blowing that into your nose. Again, works great. It does have a couple of limitations in that instead of being limited by the amount of gas you have, you're limited by batteries. Of course, with our technological world, we're all very familiar with our phones running out of battery, or whatever device we happen to be using running low on battery. That's all well and good when you have when you're talking about your iPhone. It's not so good when you're talking about something that you're relying on to survive. So of course you want to make sure that you have plenty of batteries around, or that you have easy access to a wall electrical supply as you're moving around. What determines what you get oftentimes has a couple of factors. First of all, it's going to be based on what your doctor prescribes. Second, or your provider, I should say, what your provider prescribes, and also depends on what your home medical equipment is willing to provide with you. Unfortunately, because of a lot of factors, including us as clinicians simply not being sufficient advocates, Congress and Medicare have kind of a weird idea of how much it actually costs to provide service to somebody with lung disease, and we see that in pulmonary rehab, and we see that with oxygen. And so they have this artificially low idea of what that is, and so for many years now we've seen progressive cuts in Medicare reimbursement for oxygen supplies and pulmonary rehab and all that kind of stuff that we keep talking about that we need. We definitely need it, we know we need it, but we haven't always been so good about sharing the evidence of why we need it with people. And so places are having to cut back on their services because it's just not economical for them or feasible for them to do a lot of this stuff. We were just having a discussion the other day in one of our respiratory groups about how it used to be fairly common for people to have liquid oxygen. If you go back to chemistry or maybe physics, if you compress something down far enough, it turns from a gas into a liquid. And so if you had the right kind of regulators and stuff, you could carry boatloads of oxygen around with you in a relatively small device. In these portable liquid systems, and then as you would breathe it in, it would turn into a gas, and it would work fantastic. And so they had a very long range. It worked well for a lot of people. Unfortunately, they were pretty expensive, and one of the RTs, the home care RTs, was sharing in the group that it got to a point where it actually cost more to just run the truck and gas money and that sort of thing to resupply people with the liquid tanks than the reimbursement that the company would get from the government. And so they started obviously eliminating those kind of services. And so we've seen that progress over a good decade now. And so a lot of these home care companies are not able to provide that kind of service. And so we've had to try to make some other compromises with the technology in order to make our limited supplies last a little bit longer for people and make it feasible for them to get out and about and enjoy their life and all that kind of stuff. And so that's why we came up with this device called a pulse dose regulator. And a lot of times maybe you have seen, if you've been in the hospital or if you've been on an older tank, you have a continuous flow device. Your concentrator, your stationary concentrator is a continuous flow device where it's always pumping out oxygen no matter what happens. Of course, that works great when you have an unlimited supply of oxygen or when you have a massive supply of oxygen, like when you have a concentrator, a stationary concentrator that's plugged in and pumping all the time, or when you had maybe one of these Helios tanks, the liquid oxygen tanks. It works great because you don't necessarily have to worry about waste. But when we realize that our inspiratory phase, when we're breathing in, is only about a third of the length of our expiratory phase when we're breathing out, we then realize that about 2/3 of the oxygen that gets pumped out continually just gets wasted. When we have a limited supply, we want to budget that a little bit more efficiently. So we have these pulse dose regulators that only that are able to sense when you start inhaling and only deliver a puff of oxygen when you inhale. That's why the newer systems, when you breathe in, you'll kind of hear them go psh, 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 because they're only delivering a certain gust of oxygen when you need it. That's why sometimes they're called a demand regulator or a pulse dose regulator. And those work great, again, for budget purposes, but they do have a couple, for gas budget purposes, I guess I should say. A couple of drawbacks there are that, first of all, even though the regulators and even the portable concentrators that do this pulse dosing will have a number setting on there, like 1, 2, 3, or 4, that doesn't necessarily correlate to the original continuous flow setting that you were probably measured on. A lot of people don't really realize that, and oftentimes we don't do a great job teaching that. But one company's setting of 2 may be completely different than another company's setting of 2, and neither one of them relate to 2 liters per minute of continuous flow. So it's very important to get tested with the device that your provider is aiming to give you to make sure that you're able to determine the right settings for your capabilities so that you learn what setting to turn it to when you go out for a walk or when you get on the treadmill of pulmonary rehab or when you do all this stuff and your internal oxygen demand goes up. You need to be able to compensate for that with the appropriate setting. A solid durable medical equipment, home medical equipment provider will do kind of a test drive with you before they send you on your way with any kind of equipment to make sure that it's going to fit your needs. And if you have not been offered that, demand it, because that is your right, and that is your it's your life, it's your breath, it's your life, and you deserve that, to know that what's going to be what you're being given will service your needs. A few more things with oxygen here. Last year there was a study that came, real quick before I get into that, I do know that a lot of these portable concentrators, or a lot of them on the market, and a lot of this stuff may seem very confusing. Fortunately, there is a guide available, and this is one of the things I actually left in my office. I thought I grabbed it and I didn't. But my professional organization, the American Association for Respiratory Care, has created this guide to portable oxygen concentrators, which is many pages long, but has a lot of detail on the capabilities and the capacities and the technology behind a lot of portable concentrators. And through groups like the COPD Foundation, we've been able to make that accessible for free to anybody who is interested in it. I just posted the link there. So I urge anybody who is not on a portable concentrator and is interested in getting one, or just wants to get some information to find out, make sure that you're getting the right kind of technology and the best thing that suits your purposes. Go to that link, download that. You can either look at it on your screen, or you can print it out free of charge and get a little bit more information about the technology that's out there. It is a couple of years old at this point, but most of this stuff is still pretty relevant. There haven't been a lot of new devices that have come out over the past few years. But just bear in mind that there may be an option or two out there that is not covered in this particular pamphlet. But this gives you a great base of information on what to look for, and some resources to contact the AARC to give more information about what's out there as they work on renewing this. And also, I encourage everybody, if you are having trouble with your oxygen provider, to contact the COPD Foundation. You can call 1-866-316-COPD, or go to their website. They do have a lot of resources available to help you advocate for yourself, and to speak with your clinician about getting the right kind of equipment that you need and deserve, so that you can be active out there. Along the lines of speaking with your clinician, there was a report last year. There was a big study that's been kind of controversial in the COPD world called the LOT study. It was long-term oxygen therapy, whatever. We call it LOTT, LOT. This was a study that was funded by the National Institutes of Health, because the thought was we had very good data that told us that once we got below 88%, you really needed oxygen. And that's been our standard of practice for a long time, and we've got a lot of evidence for that, and that works great. But then people started thinking, well, what about that area, that kind of gray area we talked about, where you're between 88 and 92 and you're pretty low, but maybe not necessarily that severe resting hypoxemia, as they called it. Maybe those people would benefit from it as well. And so they did this very long study, I believe it was close to 10 years long, where they gave oxygen to people who were into that moderate range, what they call it, where you were 88 to 92 either all the time, or if you happened to dip into that zone when you were exercising. And what they found, what they published, was that there really wasn't a lot of benefit in that group. We didn't see a lot of change in hospitalizations. We didn't see a lot of or a lot of change in mortality. Didn't see a lot of changes at all when it came to that more moderate range there. And so they published that, and that was kind of what it was. It didn't really make a lot of changes in what we should be doing, or didn't claim to make a lot of changes in what we should be doing, didn't make a lot of changes in current practice, so on and so forth. Unfortunately, a lot of news outlets and stuff grabbed onto the headline and went with a weird version of it that said, oxygen of no benefit to many COPD patients. And while objectively, factually, that may be true, because many people with COPD don't have a lot of oxygen need or supplemental oxygen need. We need to worry about more. We need to worry more about personal breathing and medications and that sort of thing. lumping everybody into that category really didn't do a lot of benefit to anybody. And so a lot of clinicians went out there and looked, oh, well, I've got a person on oxygen, but they're not getting any benefit from them. I better cancel that. And so there's been this whole uproar in the community about, well, my doctor is saying you might take my oxygen away, or my NP and PA are saying maybe I shouldn't be using the oxygen. A lot of that stuff is going on, and unfortunately the main message has kind of gotten missed, in that what we have been doing all along shouldn't change. Even our latest iteration, the 2017 guidelines from the Global Initiative for Chronic Obstructive Lung Disease, GOLD, says flat out, the long-term administration of oxygen to patients with chronic respiratory failure has been shown to increase survival in patients with severe resting hypoxemia. Again, the standard of care hasn't changed. What we've been doing all along hasn't changed. So it's important that we keep all of our clinician colleagues on the same page and make sure that we're actually doing the right thing by all of our patients. If your clinician is saying that they might have to take away your oxygen, make sure you're asking why, make sure you're getting all your test documentation, and again, you can contact the Medicare Ombudsman at 1-800-MEDICARE or the COPD Foundation, and they will all be very happy to advocate for you to keep the oxygen if you feel that you need it. Again, you can go into even the frequently asked questions that were associated with this study, and it will say, there are a lot of other factors that go into determining whether somebody needs oxygen or not. So please don't let anybody take oxygen away from you if you've had it, just because they say that they should. Because another one of those things that keeps cropping up is this idea of the hypoxic drive, where a lot of clinicians are telling patients, well, you shouldn't use too much oxygen because you'll stop breathing. And that is kind of based on a misunderstanding of cause and effect. We talked a little bit earlier about how sometimes that carbon dioxide can build up and push you to breathe. It's kind of a misunderstanding of physiology that was published in about 50 years ago. And so for some reason, even though it's never been successfully proven in a follow-up study, it's one of those we do it because we've always done it that way kind of things we run into in medicine, and so we run into that. So don't let anybody take away your oxygen. Don't let anybody scare you with the hypoxic drive. Make sure that you are getting the information that you need to be a great advocate for yourself, which is why we're trying to do some of this stuff. How you can be a good advocate? Well, I'm glad you asked if you were out there thinking that. First off, we've talked a lot over the last month or so about this thing called the COPD National Action Plan, which is a document that came out earlier this year after a year of formulation and public comment periods and all that stuff. Again, one of the keys in here is to improve access to care with people with COPD, particularly those in hard-to-reach areas. And again, one of them is provide coverage and adopt regulations for providing oxygen therapy that meet the full clinical needs of COPD patients and encourage ongoing mobility. This is where we really need everybody, whether you're a clinician, whether you're a caregiver, whether you're somebody with COPD, to go out there and join us and help us fight for a lot of policy review and procedural changes that can positively affect reimbursement and things like that, to give people the tools they need to go out there and fight for what you deserve, like I said. Oh, hey, how about that? I did bring it home. See, it comes in a nice full color version also. I can show you, this has a lot of settings or a lot of documentation about the different types of concentrators that are out there, whether they have the pulse flow or the continuous flow. There are charts, there's all kinds of stuff in here. There's even, again, a survey at the back that one survey per product. This survey is being sent to manufacturers, but people can fill it out too, to make sure that everybody is getting accurate information about how best to use their portable oxygen concentrator. So we need to get all of our legislators on board. To that end, I was able to meet with 2 of my state legislators earlier this month here in Michigan, and I brought this little info sheet with me to help people understand exactly what the burden of COPD is to our communities, and what we can do to fix it by helping advocate for the National Action Plan, to do all that kind of fun stuff. And these are things that you can do also. There is nothing more powerful than having a group of people who are walking the path and living with COPD and all that stuff, marching on an office or marching on Capitol Hill or whatever your state capitol happens to be called. There's nothing more powerful than all of us working together to get to that common goal. So I encourage everybody to strap on the oxygen tanks, and let's all get out there and demand the stuff that the COPD community deserves. So with that, I'm going to take another hydration break here real quick. That is the end of our lecture time for the day, and hopefully the end of most of the soapbox time too. We're going to go back now, scroll back through, and try to get to a lot of these questions that have been asked for the last half hour or so. If you do have questions, we still have plenty of time to get those in here. And I want to say a special welcome and Black Friday, day after Thanksgiving, welcome to a lot of the people who have come over with me from COPD Navigator, and another very special thank you for everybody taking some of their time out of their Friday afternoon here, or morning, depending on where you are, to spend some time on all this stuff. So we covered the app, we covered some of the oxygen stuff, covered some chest tightness. Ginny mentions, I have had a few mornings with 86%. And that is, of course, below that 88% cutoff that we like to see people have for their supplemental oxygen. But it can also be an indicator of another issue that often goes along with COPD, and that is obstructive sleep apnea. This is a subject as a respiratory therapist that's kind of near and dear to my heart, and also as somebody who was a user of CPAP for a while, had obstructive sleep apnea for a while due to some weight issues. I always joked around that I liked it so much I bought the company, because I was setting up CPAP on a lot of people, had a very good understanding of CPAP, but then ended up having to use it myself. And so what happens is, when you have obstructive sleep apnea, some of the tissues in your neck can actually collapse down and block off your airway. And of course, when you're blocking off your airway, you're not getting the good air in, you're not getting the good air out, and everything kind of shuts down. After a few moments of that, your body starts to realize that there's a problem, and it starts waking you up enough to remind you to breathe again, or at least tense these structures up so that you can open up your airway and start moving that air again. Unfortunately, that means because you're waking up, you're not going through the whole cycle of sleep very well. You have very fragmented sleep. You tend to snore. Which means your bed partner might not have very good sleep. Your oxygen level drops when you already may have some low oxygen or high carbon dioxide, like people do with COPD, like we see in that setting. Obviously, it's a lot more issues there too. So each of those diseases can make the other worse. Obstructive sleep apnea makes COPD worse, and vice versa. The treatment for obstructive sleep apnea is CPAP, as I mentioned. That's airway pressure that helps keep some of those structures open. Sometimes we do have to put some supplemental oxygen in there to keep your oxygen levels up. But it's a very effective therapy for that, and I urge anybody who has morning saturations that are a little bit low, or if you wake up with headaches in the morning that maybe you don't really have an explanation for, or if you feel yourself dozing off as the day goes on, maybe you feel a little extra tired and that sort of thing, talk to your provider about getting a sleep study, ideally in a sleep lab called a polysomnography. But sometimes we can do these things at home too. They don't really catch as much of the mild sleep disorders, but they can be effective if you aren't able or don't want to spend the night in a hospital room getting checked out with that stuff. Oximeters also add in carbon monoxide to the total, I'm told. Yes, that is a very good point. When we're looking at your oxygen saturation, the chemical or the gas carbon monoxide actually has a much stronger attraction to the hemoglobin in those red blood cells than oxygen does. And so when you are exposed to carbon monoxide, like if you're near a fire or something like that, a lot of times that will just bind right onto the hemoglobin, and things will look saturated even when they're not. Obviously, your body doesn't use carbon monoxide very well, and that kind of shoulders all the good oxygen out of the way and latches on and prevents oxygen from getting transported around. It's usually not as much of an issue with in the setting of COPD, although we do see smokers have an elevated level of carbon monoxide because you're breathing in carbon monoxide all the time from the cigarettes or the other tobacco products. However, we do see that a lot if you were to be in a house fire or if you were to have malfunctioning appliances or things like that. We do see that a lot, and it can fool a lot of people because we put an oximeter on somebody, says 100%, okay, that's fine, but their practical oxygen saturation is actually much lower. So thank you, Ginny, for pointing that out there. That is absolutely right. How can you tell if you have a barrel chest if you're a male? Off the top of my head, I don't know that we have necessarily a ratio for that. It's oftentimes something we can kind of look at somebody, and it's one of those things, you know it when you see it. It's not, from a clinical standpoint, I might have to ask my wife, who works in bariatric medicine, whether that's really more of a symptom of anything. But for COPD and stuff, we really want to go more with symptoms and with lung function and that sort of thing in order to actually look at severity and all that kind of stuff. Barrel chest is kind of a clinical feature of COPD in many cases, but doesn't really reveal much. So Pat mentions saturation drops to 79 when I get up and go to the bathroom. That is definitely something we would want to talk about getting some supplemental oxygen with activity for. We definitely don't want to see saturations dropping below 80. One thing to bear in mind, and I touched on this very briefly when I was talking about the apps and things like that. If you have your own oximeter, this is unfortunately one of those things that you usually get what you pay for. Some of them are very inexpensive. You can go down to your Walgreens or your local drugstore and pick up a device. And they work okay. Especially they work the best when everything is at rest and everything is calm and everything is fine. Where they start kind of dropping the ball a little bit is when you start having issues, when you're at the beginning of an exacerbation maybe, or when you're having a bad symptom day, or when you're moving around. You get a lot of what we call motion artifact. As you saw when I was using my app, it doesn't scan very well when you're not still and when you're not calm. So if you're going to get an oximeter, I would recommend there are a couple out there that have the same technology as a clinical oximeter, but haven't gone through all the rigorous testing, and so they can't call it a medical device, but they can also sell it without a prescription. I've seen these more in like the $80 to $100 range. Some of them are even a little bit higher than that. I know that's fairly expensive for a medical device, but they are good and may end up being a better option for you than some of the $20, $25 options that are out there as well. If you do go with that route, make sure you correlate it with your provider's office. Maybe they should have an oximeter in there. Make sure you're getting similar data from them because there is some variation from company to company. But also know that in a pinch, be better safe than sorry with those devices, and if go with how you feel rather than what the number tells you. One of the very first things they teach us in respiratory school is to treat the patient and not the number. So they can be, especially those lower quality oximeters, they can be fooled by things like nail polish and bad circulation. So make sure that you're treating yourself and not what the gizmo tells you. So David mentions, what if my CO2 is normal? I have COPD with restrictive lung disease. It's kind of a double whammy, and of course we can see a lot of people who have normal carbon dioxide levels, even with COPD. You don't necessarily retain that carbon dioxide. Again, we go with lung function and symptoms more for diagnostics than we do carbon dioxide levels. Sometimes, again, it's kind of a clinical feature of that sort of thing, but it's not necessarily something we strictly rely on. So can we pulling away from. Oh no, this is part of the platform. This is the whole thing. So don't worry about that. Oxygen addiction. That's one of those things. I've heard kind of passing references for that. That's not really a clinical thing. I've heard people talk about if you use too much oxygen, you're going to get addicted to it. That's not how your lungs work. Your lungs, your body needs oxygen at a certain level no matter what. If you have too much oxygen for too long, there is some risk of lung damage for that, but we're talking about usually people who are on mechanical ventilators and are getting almost pure oxygen over the course of days. We can see some toxicity there. We don't really see addiction or anything like that. Under 85% begin to drool. Well, that's a good indicator that we would want to definitely get some oxygen flowing there too. On a ventilator at night and oxygen went out, hopefully like more of a non-invasive ventilator like a BiPAP machine or something like that to help take some of the load off. We've seen those work very well in the setting of COPD. A lot of times people can get fatigued, their muscle fatigue, your main muscle of breathing, your diaphragm doesn't work quite as well. And so a lot of your other muscles have to take over in that regard. And using a BiPAP machine or some of the newer things out there, like the Trilogy machine, can help take some of that load off and make it a little bit easier to get air in and out there. They do indeed do very well. Melanie mentions have COPD emphysema. CO2 usually runs, it's probably oxygen 92 to 94. Men's bringing it up to 97, 98. If your oxygen goes lower than 92, you get lightheaded, dizzy, confused, and forgetful. I'm so scared to get any lower than that. How do people survive at 88? The human body can be very adaptive, can do a lot to compensate for a lot of those breakdowns. Not everybody is able to compensate like that. Obviously, you have a little bit tighter band that we would want to look out for. And again, this is why some of these big time studies don't always help us treat individual people. We want to make sure that everybody is getting the help or the support, whether it's a medication or whether it's oxygen or whether it's exercise, whatever it is. We want to make sure everybody is getting what they need for their particular situation. So I'm not sure how people survive that low either. We want to make sure again everybody is bringing in what they need. So with that, I'm going to take a break for a minute because I do have a special guest star coming in today. This is my wife, Kelly, who is a nurse practitioner, and one of the main reasons I really work to say provider or clinician rather than physician. She works a lot with the bariatric population, has done a great job helping me and many others lose weight, has taught me a ton about nutrition that is applicable for all kinds of chronic diseases, including COPD, and is very gracious that she helps me do a lot of these events. So.
Well, these are our people. I just wanted to be able to say hi, and look at, I'm wearing purple.
Purple and orange. COPD awareness, and purple is another COPD color because that is our advocacy color for alpha-1 antitrypsin deficiency, which is the genetic form of COPD. So,
I just wanted a chance to say hi. We love you guys. Thanks for being here today. Nice job, honey.
Thank you. While we've got that mention of alpha-1 out there, we can throw this out as well. This is a free testing kit that many people can get. It's very easy to do. You can get this through your provider's office, or you can there are a couple places online where you can request one. We figure we're only capturing about 10% of the alpha-1 population, which is unfortunate because it can often be masked by things like we don't think of. If somebody smokes and has COPD, we assume it's from the smoking rather than from the alpha-1, but alpha-1 can actually make any form of COPD a lot worse. So I encourage everybody to, if you haven't been tested for alpha-1, please go out there and talk to your provider or look online. We can for different resources that are out there. We'll try to get a link up. I forgot to prepare that one. We'll try to get a link up, but get yourself tested for alpha-1. There are supplements that you can be given about once a week. You can get alpha-1 supplement injection infusion. Actually, John Walsh, the founder of the COPD Foundation, would do that. I heard several stories about how he was conducting meetings while he was getting his alpha-1 infusion. He was an alpha-1 patient himself. So definitely get yourself tested for alpha-1 if you haven't done so already, especially if you have a family history of COPD or asthma or any other lung disease, because they can often be hidden by that. So, what is a normal DLCO? DLCO is the diffusion capacity of carbon monoxide. We use that. We use a very, very small amount of carbon monoxide to actually look at how well gas can transfuse in and out of your lungs. There's going to be some variation with that depending on your lung size, your circulatory stuff going on. We usually want to see that 70 to 80% of a predicted value, which is going to vary a little bit just depending on some of your demographics, your height and your gender and that sort of thing. So not necessarily a hard and fast number, but we do want to see that within 70 to 80% of what we would predict from your demographics. So, seeing my O2 at 99 doesn't stay there for more than a couple of seconds. Well, again, some of this stuff, especially on a phone app, it's more of a demonstration kind of thing. 98, 99, 100, 96, that's all pretty much the same, honestly. Nothing to really worry too much about. If we start seeing things be on the low side of the 90s, we get concerned because there's not a lot of extra wiggle room there. But good. The way I feel is like, say after you're done running and walking around to cool off and you're done with the heavy breathing, but you still have that tightness in your chest. It is very annoying, absolutely. A lot of things that can help with that are making sure you relax a little bit, but make sure you still have a big chest. Make sure you got everything out there as much as you can, and then try to do some of the pursed lip breathing. We talked about this. If you go on YouTube and look for COPD Navigator Live heavy breathing, we covered a lot of these breathing techniques last week. But if you take a breath in, put your lips together, and blow out like you're cooling off a spoonful of soup. You can help keep some of those airways open a little bit longer, flush out that stale, nasty air, that carbon dioxide, and hopefully get rid of some of that tightness in your chest too. It can help you relax. It can help you be a little bit more focused and a little bit more centered. So try some of those techniques, and hopefully that will help. Mike, there was a discussion in Navigator today on the timing of meds. Can you please address that? Yes, I would love to. We talked about meds a few weeks ago, and I believe it was our first one for COPD Awareness Month. But I do want to talk about that did pop up today. For a very long time, we were taught, when I was in respiratory school, we were taught that people should use their rescue stuff, their short-acting stuff, their albuterol, their Atrovent, that sort of thing first, to help open up the airways and to make sure that the controller medications, like your steroids and your long-acting medications, your Spiriva, your Symbicort, those sorts of drugs. Disclaimer: I am not on any speaker panels, not reimbursed or remunerated by any drug or equipment company. So if I happen to throw a brand name out there, it is simply for reference or for an example, not as an endorsement. That said, when we want to do the rescue stuff first, open everything up, and then take a deeper breath to get the controller medications in there. There is a competing theory that I've learned about in the intervening years where you actually should do the controller medications first, because what happens is those medications have kind of first claim on a lot of the chemical receptors inside of the lungs, and helps that last longer and be a little bit more effective. And then if you need it, do your rescue medication later on to kind of get you over the hump and get your day started right and all that sort of stuff. However, there was a discussion today and frankly that makes a lot of sense to me, especially when we look at some of the drugs that we have out there. In the US, for example, the medication Symbicort is considered a controller medication. In other parts of the world, Symbicort is a rescue medication because it tends to kick in fairly quickly. So what do we do? How do we reconcile a lot of that stuff? It kind of makes logical sense to have the most receptors hit those the controller medications and so on and so forth. However, another respiratory therapist I was speaking to today said that there's actually some new data out there. We're looking to try to get some of those sources out there to try to figure out or that we don't necessarily see a lot of that receptor competition as much as we thought we did. And so it is okay to take the rescue medications first to open up the lungs as much as you can, to go back to the old school theory. Unfortunately, we have not really studied this a lot in general. The more cynical members of our community will say there's not a lot of money in researching the best way to take your medications, so that hasn't been studied. But for whatever reason, we haven't really looked at what the optimal order is. We have a lot of theories and we have a lot of anecdotal evidence, but we don't necessarily have a lot of the good randomized controlled information out there. So my advice right now, I tend to stay with the controller first group. But what I really recommend to people is do what works best for you. Try both ways. Again, there's not a lot of data out there that says that one is bad for you or is going to hurt you or anything like that. So if you feel like maybe you could be getting better symptom control, try switching the order around a little bit. Definitely take your bronchodilators, your LAMAs, your LABAs, all that kind of stuff before any kind of steroid. If you have a separate steroid, if you have a QVAR or a Pulmicort or something like that, take that last, because that is never going to bronchodilate you and that's never going to open anything up. But if you have, if you're taking an albuterol and then a Symbicort, try switching it around a little bit. See what works best for you. Everybody's biochemistry is going to be a little bit different. Everybody reacts a little bit differently to medications. So see what works best for you and see if you can optimize your individual regimen. So hopefully, Bonnie, that answers that. And it's probably, the answer is about as clear as mud there. So, but we don't, like I said, we just don't have a lot of data. I would love to see more data, and that's actually something I'm hoping to do at our medical school, but we're just not there yet. So Pam wants to clarify something, that even though too much oxygen cannot stop you from breathing, people should not turn up their oxygen without a doctor's approval. As a rule, that is very true. If you are sitting at home and you just feel a little bit short of breath, you don't necessarily want to go crank up the oxygen to 5 liters a minute. However, depending on your clinician, and this is definitely something that you should discuss with your provider, as you get familiar with oxygen therapy, there are certainly situations where you may want to do, or you may be able to do, a little bit of self-titration. This is a fairly new concept in a lot of places. A lot of clinicians have wanted to have that real pinpoint control because there's been this fear of the hypoxic drive and all that kind of stuff. But my preference personally is to give people the tools they need to be able to manage their own disease effectively. And part of that is trusting people to use oxygen responsibly. You might need 2 liters when you're sitting on the couch. You might need 4 liters if you want to go on a treadmill or an elliptical or something like that, or ride your bike around a little bit. And you should be able to discuss with your clinician to have that flexibility. If you have not discussed that, then by all means stick with what you have been prescribed. Oxygen is a drug. Oxygen is considered a medication under a lot of different philosophies. So just like I wouldn't advise you to take 3 extra blood pressure medications if you were feeling bad one day, I don't advise you to just willy-nilly change your oxygen unless you have discussed that with your clinician, your provider, and unless you have a very good understanding of how to adjust those needs based on your oximeter or based on your rate of perceived effort and all that kind of stuff. So very good point, Pam. Don't change it unless you have been authorized by a clinician to do so. Could an enlarged thyroid cause you to feel like it's hard to breathe? Absolutely. If you're starting to get, anytime you're messing around in your throat there, you can have sensations about being difficult to breathe. Any kind of growth or any kind of inflammation can definitely affect that. A lot of people vape instead of smoking. Is water vapor in itself hurtful to your lungs. Water vapor is not. However, there's a lot of other stuff in a vape that can certainly be harmful to you. A lot of those vape liquids are not just water. There are things like ethylene glycol, and they have a lot of preservatives, and they have a lot of other stuff. And we have absolutely no idea what the long-term effect of that stuff is going to be. We know that it's probably not great for you. It's certainly not as good as just good old-fashioned air. We also know that vapes and e-cigs are not don't have a lot of evidence right now to support their use as quit smoking tools. So it's not something I recommend anybody pick up the habit of. Because we just absolutely do not know what the long-term effect is going to be of these particular things. So water vapor in and of itself is not, but a lot of the other vapors that are part of the e-cig are. To be honest, I'd like to vape medical marijuana if water vapor isn't all that harmful to the lungs. We can vape an oil that isn't burning a flower or plant matter that is a lot healthier for the lungs. Unfortunately, can't really speak a lot to medical marijuana in any particular form. That because of the controversy surrounding that, it is still illegal at the federal level. A lot of states have gone to legalize that, and it would be good to see some more research in that regard. But unfortunately, those are not waters that I'm comfortable wading into right now. Just for a lot of reasons. I mean, I have my personal views on it. I don't want anybody to assume that I'm speaking for the foundation if I were to render an opinion there, but I will leave that to however you feel. I've got a few more questions out there. I didn't see Kelly scrolling up there, but strep throat but can't get to the doctor. That is unfortunate. Hopefully you can get to an urgent care or something like that. As soon as possible. Hopefully we can get that taken care of. So a lot of people, okay, now we're trying to catch back up here. We're getting down back toward where Kelly made her guest star appearance. Turn oxygen up when showering or during physical activity. My doctor said it was okay for that. That's exactly what I'm talking about. Just like I said, I'm a big proponent of, we have this philosophy around here in Southwest Michigan called row the boat. And I guess it's spreading over to Minnesota now because that's where our football coach went. But I believe that the care team is all in a boat together, whether me as a respiratory therapist, nursing staff, the person with the disease, the caregivers, the pharmacist, the primary care, the specialist, we're all in a boat together. And unless we're talking to each other and communicating our needs and expectations and all that kind of stuff, at best we're going to go around in a circle. More likely we're going to flip our little boat over and then we're all kind of in trouble. But if we're talking with each other, we're keeping everybody posted, we're telling what works, what doesn't work, all that kind of stuff, then that is absolutely the right way to go about it. We get from point A to point B where you're living your best possible life and with a successful care plan. So definitely, like Rachel, keep everybody posted and make sure that everybody's on the same page. So when you get a pulse ox of 94%, that's pretty good. Unless you, again, have been in a house fire or something like that. But 94 is definitely within the normal range. My Pro Air, Ginny says, gives me anxiety and raises blood pressure. Takes long to work, maybe 15 minutes. Only lasts for about 2 hours. Also use methanol as a propellant, and I'm a recovering alcoholic. That is worrisome as I get some weird effects. Are inhalers without alcohol? The biggest things that are not going to have any alcohol are dry powder inhalers. They're not always my favorite because especially people with more severe inspiratory flow problems have some trouble activating them. But they can be a very good thing. Albuterol does come in a dry powder form. It's actually made by the same people that make Pro Air. I think it's just called Pro Air DPI instead of Pro Air HFA. So I would, if you're concerned about that, I would definitely look into that. Albuterol can give anxiety no matter what form it's given in, because it is a distant cousin to adrenaline, epinephrine. Works on that same kind of chemical pathway, the fight or flight reflex, where it can raise your blood pressure, raise your heart rate, all that kind of stuff. And so that hopefully you don't have to use it all that often. If you're using it a lot, that might be an indication that either your regular your controller medications aren't sufficient, or maybe we need to look at the inhaler technique or things like that to make sure you're getting the maximum efficiency out of your inhalers. Rachel takes Brio and Incruise first per info from, and again, this is going to be what doesn't matter to health providers what goes first anymore. I wouldn't say it doesn't matter to health providers. To clarify, we just don't know what the optimal dose is. This was actually, like I said, I've been convinced with the gentleman who convinced me. Mark Mangus has been an RT for a very, very long time and has seen a lot of success with doing the controllers first regimen in his practice. However, I also greatly respect the opinion of the person I was speaking with today, Sharon Cornelissen. Also does a fantastic job with the COPD pulmonary rehab community. And she says that there have been newer papers that I haven't caught yet, always trying to learn something new, that said we don't see that fighting for receptors. So I want to be very clear that it's not that providers don't care. It's that we just don't know, and we can't say for sure what the real answer is or what the best answer is. David mentions using ProAir increased anxiety for a long time. That might be why. Again, when you're kind of always on edge, you're always getting that stimulation. That might definitely be a feeling of anxiety all the time. We're getting ready to wrap things up here. Still scrolling down through some of these questions, but it looks like we're getting down toward the end. Let's see. Kathy, 62-year-old with a lot of illnesses. Unfortunately, we do see that with COPD comes a lot of what we call comorbidities a lot of times. COPD affects a lot of other illnesses and syndromes, diabetes and GERD, acid reflux, and a lot of inflammatory stuff. And unfortunately, all those can also make COPD worse. So we do see that many people in the COPD community have a lot to be going along with. And we need to work to optimize every single one of those particular processes. So Rachel says, explanation about portable tanks explains why I am out of breath often when using my pulse oxygen tanks. And to make it even more complicated, sometimes the pulse, sometimes changing the pulse number gives you a bigger bolus of oxygen. Sometimes it gives you a more frequent bolus of oxygen. There's each company, each manufacturer has different strategies. A gas regulator is different than the concentrator regulator. There's so much out there. It's difficult to match the person with the right equipment. So don't give up, but keep working with your provider, your equipment provider, to get some equipment that works for you. Pamela, why do they use the highest oxygen reading instead of the lowest? I sit down, it'll be 93 and drop to 87. They take the 93. Depends on a couple of circumstances. Depends on the quality, the signal quality of the reading. When I did, let's see if I can bring it up again real quick here. If we look at a good oximeter is going to give us a waveform reading. We want to make sure that the wave, you're actually getting a wave that represents your pulse. If you're just getting kind of a line and it says 87, then it's probably not a very accurate reading. The whole idea of looking at that wave is to make sure that we're actually getting good quality information from our device. So it could be that when you're in the 90s, that's a good quality waveform, and when you drop down to 80s, that's not so good. And that can happen a lot. We can get lower numbers when we have a poor quality signal. That's why it's important to get a device that can compensate for some of those things that cause a bad signal. So that would really be a question for your provider or their office, whoever is doing the measurement, to find out why they're going with that number, because there are a lot of variables there. If you're getting good quality information and it's still 87%, that's where I would go with, but there are a lot of variables to consider. So unfortunately, got to redirect that one to your individual provider. Holland, hopefully I'm saying that right. Flovent gave me thrush. Yes, many inhaled steroids do. That is a very common side effect. And make sure you're swishing and spitting. Sometimes you need to even get a more powerful mouthwash to prevent that. But definitely rinsing out every time you use a steroid like fluticasone, which is Flovent. Insurance insisted I use that instead of QVAR. Is there a way I can convince them that this just isn't the right inhaler for me? We run into that from time to time in our clinic. We actually just had a major change in our formulary for our Medicaid program, so we've been having to switch over a lot of people from one medication to another, and in many cases that doesn't work very well. Most, if not all, providers have what's called a formulary exception form or a formulary exception request, where your provider can fill out some forms. Usually they have to go track down a couple of studies, and they're able to request a medication that maybe isn't necessarily on the formulary or isn't a first-line medication for you if you have a documented side effect, and it sounds like you absolutely do. I will say in a case like this, they will probably want to document that you're actually doing the swishing and spinning properly, and making sure you're doing the proper technique and all that sort of thing. But it is possible. It just takes some extra effort and work on the part of your provider. But if that's the route you want to go, then I would hound them on that. Ask them for about the formulary exception process. What do I think of CBD oil? We're going to lump that in with a lot of the other cannabis discussion, and unfortunately just going to bypass that one for right now. I know it's not maybe quite as controversial, but what I will say is that there are a lot of people out there. There are a couple people in particular who are very strong advocates of this oil, who are making claims that are based with absolutely no evidence or any kind of science behind them at all. So be careful who you listen to, and I realize that as a person on the internet, I'm telling you to be careful who you listen to on the internet, but I also am realistic enough to know that what I do is give you general advice that you can take back to your provider, and there may be very good reasons why your provider is going in a different direction than maybe some of the advice you get from here is. There are a lot of factors that are involved in good COPD care, any good chronic disease care, and we can't account for all of those online like this. So be wary of anybody who is telling you that they are right and everybody else is wrong. That's all I'm going to say about that. Thank you, David, for your kind words there. Get a lot of that's just how it is with this disease. Unfortunately, that is still the case. We are seeing that trend down a little bit. There was a study that came out last year where we saw distinct trends in the reduction of what we call therapeutic nihilism, or the belief that we can't really do anything about COPD. We have seen that over the last 5 to 10 years, but we do still have a long way to go, especially as we're trying to do better at managing COPD in primary care, where people have a very limited time to handle a lot of diseases and aren't always able to stay up on a lot of things. My role, I'm hopefully a prototype of a new generation of respiratory therapists. I'm actually in a primary care office doing a lot of these management things and trying to take the load off a lot of these clinicians. Unfortunately, that's the exception rather than the rule, but we are working to change that. So thank you very much for your kind words, and know that we're trying to move stuff forward. They are terrible, but my insurance only uses them. Okay, not quite sure what Rachel's mentioning there, but we are going to wrap things up. Stiolto will not cause thrush, apparently. That is true. Stiolto is a combination med of a long-acting beta agonist, like a long-acting kind of albuterol, and Spiriva, which has been a very well-known, well-received, long-time, outstanding, honestly not paid for, not reimbursed by BI, so this is my honest clinical opinion. It's been a very good drug for a lot of people, but you're absolutely right, Stiolto does not have that steroid, so will not cause thrush. That is a very good drug. Unfortunately, it's still not on a lot of formularies, so it can be difficult to get, but it is one that I hope to see expand out there, if nothing else, because I really like Spiriva. But thank you, everybody, for, I am in Kalamazoo, Michigan. That's where our clinic is. I work for My employer is the Western Michigan University School of Medicine, Homer Stryker MD School of Medicine, who I should also point out, they do not endorse any of this. Is all my stuff. This is not in my official capacity through them, but that is where my clinic is located and where I've had a lot of experience helping the COPD community through primary care. And I'm very excited to hopefully be a role model for many other respiratory therapists in the future. So thank you very much. Thank you, Jenny, for your kind words. I appreciate Rachel. That we had a lot of people who that's our situation right now. Took off of Spiriva, put on Incruise. That's actually exactly our situation. Nothing against Incruise. Incruise has worked for a lot of people, but one of the things I go by is a few years back, the about 3 or 4 of the big chest, pulmonary, lung professional groups like the American College of Chest Physicians and the American Academy of Allergy and Asthma and Immunology, I think it is. There's a whole bunch of A's and an I. Came together to come up with clinical practice guidelines for how to match people with the right drug, with the right inhaled medication. And a big part of that is making sure we have people who know how to use the device, who are able to use the device, where they're able to trigger the inspiratory flow, all that kind of stuff, and are willing to take the device, meaning that this isn't something that you're going to stop taking because it tastes bad or things like that. All of those things are supposed to go together for best practices to pick a medication for a person. And again, we saw that this is another part of our national action plan. We want to get back to that. I don't know that I can find the right, oh, here it is. One of the keys in the action plan that I actually highlighted it from a previous talk is to discourage substituting for non-medical reasons one prescription for an inhaled COPD treatment for another. And we're definitely seeing that that's still happening, and that's definitely something we need to focus on as we move forward into 2018 and more thorough implementation of the action plan so that we can get people on the medication that they need and can use rather than what will be paid for. So with that, I do have to wrap things up for today. I greatly appreciate everybody coming out here on their Friday afternoon, spending some time with us learning about COPD. Again, we do these every Wednesday, or we used to do them every Wednesday. We switched to Friday a couple months ago. If you are not a member, please feel free to join us at, let me see if I can type it real fast here. We are here on Facebook, www.facebook.com/groups/COPD Navigator. Please feel free to come join us. We have a great community out there. We've got people living with COPD. We've got caregivers. We've got RTs. We've got all kinds of people who care about the community and are trying to share their tips and tricks and their experience and support and everything else that goes along with managing this disease. I also want to once again thank very, very much the COPD Foundation for giving me the opportunity to present these during COPD Awareness Month through their Facebook page. Please go to their COPD 360 site. You can find me there on there from time to time as well. Another fantastic, many thousands of people living with COPD and other aspects of the community. Many thousands of people joining together to share their wisdom and all that stuff. Thank you very much to everybody in the COPD community for having welcomed me in as a cheerleader, as an advocate, as a helper, trying to help however I can. Make sure you're getting your COPD awareness T-shirts for Giving Tuesday, Charity Tuesday, whatever we want to call it. And make sure you're following the foundation for all the updates that the important work that the foundation is doing, and getting information out in the COPD community. So. Link not working. Well, it worked when I clicked on it. So, but what you can do is just search for COPD. Go to your Facebook toolbar and search for COPD Navigator. Maybe I'll try a link. Sometimes computers get a little weird, whether it's HTTP or HTTPS. So we'll try again here. If you're watching this on YouTube, hopefully we'll just have a little thing at the bottom of the screen that you can click on, but that one is working on my end. I don't know if it doesn't work. Search for us on Facebook, or you can look for Mike Hess from Kalamazoo and send me a message, and I will get you added to the group as quickly as I can. Thank you all very much. I hope everybody had a great Thanksgiving. Hope everybody has a fantastic weekend. Take care of yourselves, take care of each other, and we'll see you next week.